So I would say that whenever you're treating a patient with low back pain, everything you're doing is motor learning. There is no separation if you are giving physical therapy rehabilitation. Because everything that you're doing is specific to the individual in front of you and teaching them how to move differently. If you were to just do general strength training, that's not skilled. So if you're delivering skilled rehabilitation, everything that you're doing is in part motor learning, I would say, based on the definition that I would use. Because general strength training would not be specific to an injury. I think you always have to have the context of the individual, right? The way in which I would treat a 65-year-old grandma who has back pain bending over to pick up a grandchild is different than some of the Olympians that I come see with back pain, right? From everything from the first exercise you give them to their last before discharge exercise, it's all individual to the person in the context of how their back pain presents, what specific type of exercises they need, the amount of loading that we're doing. But I'll give you a general sort of way that I would go about certain things. Is that the first and most important thing when it comes to back pain is discovering with your evaluation, which is going to be part of your subjective, objective, and everything else that you're doing, finding out what specific motions, postures, and loads trigger the pain, right? Because that will show you what that person's specific movement problem is triggering the symptoms. The reason that's important to understand is because you can give them any exercise, the best corrective exercises in the world, but if you don't teach that person why their pain is there, it's not going to get better, or it's not going to get better faster, or what you're going to do is only going to be a temporary fix. And if you look at a lot of the research I'm sure you guys have looked into, most of the research articles are only like 10, 12 weeks long, right? Well, a lot of times you can see a short-term change in pain in a short period, but what's that follow-up look like at 2 years, 4 years, 10 years down the road? So if I have someone that has back pain bending over to pick up their child, sure, I can give them a lot of glute exercises and core stability work, but if they don't learn how to move differently, motor learning, every time they bend over to pick up their child, they're pushing their back into their specific pain trigger. They're probably going to continue that cycle that's continuing the pain. Make it better in the short term, but long term, they're going to keep on re-injuring themselves, which is why you see the re-injury occurrence rates are so high with back pain, right? Even though you see in the short term, most people say like, oh, most back pain clears up in X amount of weeks. Sure, it might, but what's the reoccurrence rate? Because a lot of people have back pain that reoccurs very frequently throughout their life because they're never addressing the root cause of the problem. So once you have that sort of figured out and you've explained that to the patient, then we have a very simple process of mobilize what needs to be mobile, stabilize what needs to be stable, and then integrate those things into loaded movement. Now that section is then individual to the person, right? Me teaching that 65-year-old grandma some loading movements is not going to look the same as me working on a 3-time Olympian, but they may have similar principles. But that strengthening is how we're actually taking the changes that we're getting with mobility and stability, and we're building capacity in movement quality and their ability to tolerate those loading cycles that were once triggering their pain, so that they don't have that reoccurrence in the future. That answer your question? It always has to be specific. That's why research on low back pain specifically is very vague. He'll say, oh, this works, this doesn't work. These people get better, but these people didn't get better. It's very confusing sometimes when you look at the breadth of research, but it's because when you have a patient in front of you, you don't have a research article, which is an average of norms at a specific stimulus, right? You have an N of 1 in front of you. And that person has a lot of different things that are going into that development of back pain. So I can't just treat them generally. Right. There's no such thing for a physical therapist as non-specific low back pain at all. A surgeon may look at that because they're trying to specifically target a tissue that they're trying to cut out or inject or something like that. But for a physical therapist, there's no such thing as non-specific low back pain. But if you take that approach of non-specificity with your treatment, some things work, some things don't work, some things make people better, some things make people worse. I get people that come to me all the time that say, I went to 5 different physical therapists and nothing got better. One person made it work. What were you doing? Oh, well, I had back pain, and they said just do a bunch of McKenzie press-ups, or just stretch my back. Or I went to 5 chiropractors and they just adjusted. They didn't do any exercise after. Or my hip hurt, so I just was doing a bunch of clamshells. That's non-specific. If we're not specific with our intervention, and we're not giving a skilled intervention, that's actually going to create a long-term, lasting result, because we're not actually addressing the root cause of someone's pain from a mechanical standpoint. Because as a physical therapist, you're the movement expert, so you need to be able to give them a specific intervention based on that. Some people, it's knowing, do I need to give that person more motivation? For some people, maybe I need to teach them to sort of calm down how frequently and intensely they're doing all their other stuff. For example, I'll give you 2 people. One person is the 40-year-old soccer mom who's got 3 kids. She's got back pain lifting her kids up. And I need her to do a few different corrective exercises throughout her day and change the way that she moves. But she's so busy with her 9 to 5 and working with 3 kids, and this kid at the soccer practice, in this case one of the gymnastics. She's so busy that she doesn't have time to do her corrective exercises, and she forgets to do her different ways of moving. That's a different challenge in how you're approaching that person's rehab than maybe an Olympian who their entire life is training and recovering. But sometimes it's tough for them to take a small step back in training 2 times a day, because they're like, well, if I take a step back, then I'm not going to hit this next goal and then do well at this next competition. So you have to approach that person differently. And we have to understand, well, that person, maybe it's a little bit more of discussing their workout routine and saying, hey, let's scale this back a little bit, but I want you to do these 3 corrective exercises every time. Whereas the other person, the soccer mom, it's not as much as about, hey, I need you to do these 5 corrective exercises, because that's too much for her. She's got a busy life. But if I can teach her how to move a little bit differently during her day, maybe give her like 2 things to do, now she can have a better chance at finding resolution of her symptoms. So understanding how to approach each person differently based on the context of what they're bringing to you is where you'll see the biggest long-term benefits for both those people. Because if I give that 40-year-old soccer mom 7 exercises on her first day, she's not probably going to do them. So I need to spend the majority of my time talking to her about how she moves, showing her how to pick up her kids, and maybe give her 2 things to concentrate on. That's it. And then she'll have a much better adherence to that program and probably do much better long term. If you give that person 7 things the first day, they're probably not going to do that. Right? So that's probably, I would say, maybe the biggest challenge is learning how to apply a similar program to different people. This is our box of laundry that I'm going to pick up a couple times throughout the week, right? Most people, they just generally just sort of bend over and pick it up, and it's a couple pounds off the ground. Most people, it's not a big issue. But for a lot of people that come in, they have back pain, bending over to pick up loads. So I can give them the best corrective exercises in the world, stabilize their core, work their glutes, everything. But if I don't teach them, hey, how do you bend over to pick something up? I'm not actually doing a skilled job of that full comprehensive evaluation. Part of my eval is literally just teaching them, hey, we're gonna come here. We're gonna put your hands into your thigh, push down, come down to the top of the knees. It's called the shortstop squat. Or if you get someone from India, you ask them about cricket growing up, and they're just resting their hands right here. And maybe if they have any pain, all right, adjust, flex, extend, find that middle ground where you're like, hey, I feel comfortable here. Then we do this a couple times. And we're learning to hinge. Most people with flexion-related back pain have no idea how to hinge. So now I'm in a hinge, then I can squat down, then I can pick this up. And on the way down, I'm going to reverse it. I'm going to hinge and squat down. Now I showed that person how to perform a daily exercise or movement that they did that created pain, how to do it completely pain-free. And now throughout the day, there's less irritation on that part of their back, which means inflammation can calm down and pain can start to slowly wind down. So we can desensitize that person, because if I don't teach them this, it's like that person's going outside and just stubbing their toe every so often. Their toe's going to get extremely irritable because they're never addressing the root cause of their movement. I find it far easier. And the reason for that is Olympic weightlifting is very different than most other sports in that it is an extremely technical sport. We call it ballet with a barbell. And the reason I mean that is that you can be extremely strong and be a really bad weightlifter. So weightlifters typically have a very good awareness of their body. They know how to adjust their body under load. And they also, when they've been doing it for a while, understand the importance of a proper warm-up and how they can feel differently if they do warm up or they don't warm up. So your typical gym bro goes into the gym, and let's say they're gonna do bench press. They go right to the bench press and they grab the bar and they do 20 reps and they start throwing some weight on. An Olympic weightlifter at a high level will have a 20 to 30 minute warm up before they touch the barbell. And then their training sessions last 2 to 3 hours typically. So Olympic weightlifters are much more receptive to corrective exercises and motor learning things because all of their training is motor learning.
Yeah, that's
Does that
very
make sense?
interesting. Yeah.
Like when so I've been in the sport of Olympic lifting since 2005 is when I did my first competition, but I started training Olympic weightlifting, at least parts of it, back in 1999. And when you train Olympic weightlifting, you don't just go to the gym to lift weights. You go to learn. Does that make sense? And you go to perfect certain aspects of the technique. So you're not just going in, it's not just brute force. You're constantly working on specific angles and motions and this feel and working out your technique. And in doing so, then the big lift numbers go up. So that's why I think Olympic weightlifting has such amazing carryover to the process of physical therapy, because it is so motor learning